Welcome everyone to our first educational grand round that is actually being recorded and is virtual. It gives me immense pleasure to introduce our today's speaker, Dr. Carey Roth Bayer. She's a professor in the Departments of Community Health and Preventive Medicine, as well as medical education at Morehouse School of Medicine. Her scholarship focuses on training health professionals to address human sexuality with patients across the lifespan: sexual orientation, gender identity, gender expression, safe space, and inclusion training. She holds national and international leadership positions with the National Coalition of Sexual Health as the Society for Scientific Study of Sexuality. Dr. Bayer co-led the development of competencies of reshaping North American medical education, curricula in sexual health, as well as sexual orientation, gender identity, and sex development. She was recently named as Teacher of Distinction at Morehouse School of Medicine Teaching Academy. She's also designated as one of the 50 revolutionaries in sexual and gender health by program in human sexuality at the University of Minnesota. She has received Distinguished Service Award from Society of Scientific Study of Sexuality, as well as Professional Standard of Excellence Award from American Association of Sexuality Educators, Counselors, and Therapists. She earned her Bachelor's of Science in Nursing from Xavier University, a Master's degree of Adult Education, and a doctorate in Human Sexuality Education from Wagner University. She is certified sexual educator. Dr. Bayer's favorite place in academia is in the classroom, helping students actively learn how to make the world a more sexually healthy place. And she's going to do that for us. So welcome, Dr. Bayer.
Thank you so very much for that great introduction. I'm super excited to be here with you today, albeit virtually. I'm going to probably do things maybe a little differently. I know that there's mention that this is the first virtual grand rounds that you've had, and I'm a pretty active, engaged, and I want you to be able to take away things from this. So if you're not oriented with the chat function in Zoom, I invite you to search for that. It should be at the bottom of your screen. That's the place where I'm going to ask you some questions. I'm going to ask you to put some of your thoughts, your expectations, your reactions as we go along. My hope is to be able to leave you with some practical tools, as well as have some conversation that you can apply there on your campuses with your students, with your faculties in your institution. So I will also show a video, a brief video again, so hopefully you can have some more ideas. And let me get my screen share here, and we'll start the slides. As you heard, I'm Carey Roth Bayer. I'm going to pause for a moment to tell you that my pronouns are she, her, and hers. And I want to show you, this is my badge at Morehouse School of Medicine, and on my badge I have a button that says ask me my pronouns, and I have a button that says what my pronouns are. And you might think, well, why is that important? Why does that matter? And that's a lot that comes into play with the topic of conversation that we have today, which is, what are your students and your patients' identities? What are the identities of the folks that you are working with? And is there a way that we can create dialogue and make it easier to be able to have commonalities and to have discussion? And pronouns are one of those ways, because if we can start off by being able to call people what they want to be called, let them tell us what their labels and their identities are, it makes our ability to kind of start off on the right foot that much easier. And so I give that little tidbit for you, whether it is, and I think because I've come into this Zoom in a different way than I usually do, even on my Zoom name, usually what I will have is my name and my pronouns after it. If you didn't have the visual to go with me, you might have not known, or you may have had your own ideas about what my identity was. So I paused there just to kind of call attention in that space. I wanted to start out with acknowledgements, which is to thank Dr. Zun and Christina, who have been awesome, and we chatted about this. We tried to come up with something that was going to be most pertinent for those of you who are attending today. I also want to thank the Association of American Medical Colleges Advisory Committee on Sexual Orientation, Gender Identity, and Sex Development, because some of the work that I'm going to talk about is a work that was done with a lot of great minds coming together in these areas. And then a lot of what I do connects with the students that I get to work with, and I'm the faculty advisor of the Morehouse School of Medicine Alliance Group. And those student leaders teach me a lot, as I'm always open to learning. The field in gender in particular, as well as sexual orientations, continues to change rapidly. And the best way that I'm able to continue to help my students be successful is being open to learning from them. I know this is a CME activity. I don't have any financial disclosures to give related to this presentation. And I also wanted to let you know that these are the learning objectives for the session, in case you haven't seen them. We're going to do some language distinctions, so looking at those differences related to sexual orientation and gender identities, two areas that often get lumped together. We're going to talk about some strategies for creating safe spaces with your students. And then we're also going to talk about some strategies for including content in your med school curriculum. So at this point, get those chat functions ready. What I would love for you to do is, as you look at this image and you think about why you gave up an hour of your time today to come listen to this presentation, what were some of the expectations that you had coming into today? So if you can just, whatever first comes to mind, jot those in the chat, that would be great. Give a couple minutes here, a minute or so for the chat. Okay, so hopefully as you are looking at these different words that are popping up, you have orientation differences, unconscious, competence, identity, development, we have implicit, behaviors, LGBTQ, we've got sensitivity, sexual culture, humility, bias, gender, experience, spirituality, expression. All of these are words that apply to what we're talking about today. So let's go directly into our language. And when we think about the language terms that are going on, and you are thinking about your students, you're thinking about your environment that you're working in, you might be thinking about what's some of that language that I use or I hear used or might be used when I'm teaching. Maybe you have an equity, diversity, and inclusion office on campus, or you have other programming on campus. And what we've historically seen is we have seen that folks will lump together, and even as we were talking about today, whether we should say LGBTQ+, these different layers of identity in an attempt to advocate for rights, to enhance visibility. But in that lumping of these identity layers, sometimes populations get lost. And so this, the genderbread person, if you haven't seen it, Sam Kellerman has put this visual together. It actually comes out of work that came out of the early 90s, and Sam has had various renditions of this in order to kind of help give that distinction between, so identity, what we're thinking in terms of the brain, so what are those gender identity labels that I pick. And this is one of those tips up front, is a lot of times in medicine, and particularly in a world, especially when it comes to population health, We want to be able to put people in boxes in order to count, in order to extrapolate. And the challenge on that is that not all of those boxes truly represent individuals. So we have to get into a place where we're allowing folks to be able to give those identity labels to us versus us putting those identity labels on folks. That heart and the little line that says attraction, so that's, you know, who am I attracted to? And a lot is moving in this space. You're seeing at the bottom of it, you know, am I sexually attracted to someone who identifies as a woman, a man, identifies as genderqueer or non-binary? A lot of our social constructs initially were built around these binaries in terms of male and female. And as the gender field has moved and grown, we're seeing a lot of expansion in that fluidity space, which is seeing the work grow in a more of a fluid, more of a spectrum. And that might be an area for you to take a step back when you think about the content that you're teaching with your students. What are some of those pieces that come to mind for you that maybe you're immediately going to a man or a woman versus, say, if I were teaching about OBGYN and instead I might just label a uterus versus saying a woman's uterus. So if I said just uterus, I might be more inclusive of my populations who fit on the gender spectrum who may still have a uterus but may not identify as a woman. You see the term sex, and this is really referring more toward anatomical sex, different from sex behavior. And with that, oftentimes that's how those first inklings of gender are getting added on. So you even think about when somebody finds out that they're pregnant, one of the first questions they may be asking is it a boy or is it a girl? So gendering is already occurring before we are even bringing in the social factors of that person's beginning journey in life. And then expression, you see the dotted line that goes around to the left, that's how I dress. So if you got up today and you looked at yourself in the mirror and you said, hey, am I going to get on Zoom? Am I going to turn my camera on? What am I going to look like? How do I want to present in the world? That's part of your gender expression. So am I going to present in a more masculine manner and a more feminine manner? And what does that mean in terms of how I interact in the world around? And in this visual, I think the key is the gray area that says that identity doesn't necessarily mean the same as it doesn't line up with expression. It may not line up with sex. It may not line up with a gender label, and it may not line up with sexual orientation. And I will take this one step further to say that it may not line up with sex behavior. And oftentimes we see that when we have terms like men who have sex with men. So that is describing a behavior. It's not necessarily describing a sexual orientation. So I want to go to a little bit on language. And this is where some of this distinction happens as well. And you might be thinking about what sorts of language are you using when you're teaching in your classes, whether that's in the research arena, the clinical arena, whether that's in the education arena. And what are those identities that you're using? Are you using them? So sexual orientations, if we think about that genderbread visual, that is really speaking more to who am I attracted to? And it does, in some sense, have a connection to that gender spectrum. So for folks who identify as asexual, they may still be interested in a romantic connection, but it may not be a sexual act sort of connection. In a bisexual space, somebody may be attracted to those who identify as male or those who identify as female, but it may not move more into an attraction on a gender spectrum space. Our gay, our lesbian, our homosexual, our same gender loving tend to be an attraction to someone who identifies within the same gender. Pansexual, we're seeing more and more visibility around pansexuality, and this is a bit of a more encompassing label, both this as well as queer. I'll talk a little bit more about queer here in a second, but in the pansexual space, we're seeing more folks in the trans space. So if they identify as a transgender individual or someone who is gender fluid, gender queer, their attraction is not necessarily labeled by a specific binary gender space, and that pansexuality allows for that fluidity and movement across. Queer, I call to this term a little bit of attention because if you are in the elder populations, this may be a term that may be perceived as derogatory. As we see with language over time, especially as younger generations come along, they tend to take language and sort of reinvent it or give new meaning to it and embrace it. And queer is a term that's being used currently in sexual orientation space. And then also straight heterosexual tends to be a description of what we'll talk about here in the gender identities and expressions. You're kind of cisgender, so male, female relationship. I bring and pause on the sexual orientation space because I really want you to think about in your content, in your curriculum, even in your work environment, are there assumptions that are made about your students, about what medicine looks like, about what patient care looks like, that maybe not all of these orientations are given that same visibility? This week, at the beginning of the week, I'm not sure if the talk was set up. I think our talk was set up today based on scheduling, but at the beginning of this week was the National Coming Out Day, or recognition of National Coming Out Day. And you might say, well, why is that of importance? Well, visibility is important because if I can bring my whole self into the learning environment or my whole self into the work environment, then I don't have those added layers of stress of, am I going to be outed? Am I not going to be supported? Am I going to experience microaggressions? Because instead I'm valued for what I bring into those spaces. We go to the gender identities and expressions column, and you can see androgynous, cisgender. So cisgender and transgender are these two terms that you may be most familiar with. So cisgender connects more to, does the anatomy that I have or that I was born with line up with the identity that I choose to have and live throughout my life? So if there's congruence in those, then I'm identifying as cisgender. If there's incongruence or the anatomy that I was assigned with at birth differs from my gender label, that's where we get into our trans spectrum spaces. I call attention to the femininity, masculinity piece because this is where we start to see particularly some of the microaggressions that come out as our social cultures have changed, particularly in the United States. Women have, those who identify as cis women and to an extent trans women, have been able to allow and enjoy more privilege to say present in a more masculine way because masculinity has been pitched in terms of power and privilege in many ways. Femininity, on the other hand, has given more of a submission space. It has not been given quite as much in that power and privilege space. There's more domestic roles that have been attached to it. It might be reproductive roles attached to it. And the interesting part is, while cis girls or girls have been able to move in that masculinity space, boys, men, trans men have really not been given quite that same power and privilege moving in more of a feminine space. So we have to be aware that, as you know, not everything is equal. We may value equity, but within these sub-communities, not everyone is treated equal. Our gender fluid, gender queer, gender non-conforming, this is moving again across that spectrum space. Our non-binary. And so this is that non-binary means if you were brought up, and in medicine, we're really good at, saying that this is what men, this is what women are. If you think about lab values, it's a very gendered system, and we know less about the movement across spectrums. And I would say that that's something we're going to be seeing more. There are more and more gender medicine clinics popping up. So that's not just, say, you want to be on hormone treatment, which oftentimes hormones can be handled in primary care. You don't have to go necessarily to an endocrinologist or a specialist if you're in a gender fluid space. But we are seeing more and more gender medicine clinics popping up to provide that welcoming, inclusive care that may not be happening in, say, your typical binary spaces. Trans, and I have an asterisk by it, is an umbrella term that is over a number of identities. And the best thing I can tell you when you're working with folks who identify in these spaces is to ask. Just to ask them about where their identities lie. What do they want to be called? That's why when I gave the example around pronouns, is it helps to create that conversation. It helps to build trust in a relationship. If a student trusts you as a faculty member, they're more inclined to feel like they can come talk with you when they're experiencing challenges versus feeling like their identity may be getting in the way of getting to the content or the experience at hand. Coming to visibility, this is what I will ask you this question. And what does your institution do in terms of visibility for these varying populations? Are you showing visually, or do you have binaries, or are things more heterosexually focused? When you're teaching about sexual health, is it more about reproduction, or is it about connection or family creation across relationships? Is it about pleasure across relationships and identities? The flag that you see on the left, you may be familiar with the rainbow. So thinking about different symbols, the rainbow has been the traditional visible sign for the LGBTQ plus communities. Their addition of the black and brown has been a specific recognition of people of color, as they have not necessarily been included in the same way. So this gets into these multiple layers of identity. And then that white, pink, and blue that you see on the far left is a sign for the trans communities. I put up the all gender restroom sign because bathrooms become a big conversation. And I don't know if you remember a few years ago in North Carolina, bathroom bills, while it did bring more visibility to trans communities, at the same time, somebody should be able to go in and use the restroom without fear of, whatever concerns may be popping up. And this has been a challenge because of values, identity, or values and beliefs of what's happening in bathrooms, which is no backing behind it in terms of connection to trans communities. So when we put this talk together, we did talk about bias and the role that bias plays in this. And that's where we wanted to kind of take and show you that having an awareness about bias is key to doing this work. So if you think about what are those clear feelings that are happening, what are the attitudes? Everyone has them. You were born, raised with values. You're constantly in a space as a human being about judging or making a judgment. And it may just be about your safety and protection. It might be about what your academic dialogue is going to be. You can see that there's clear. So I would gander to say that we all have a bias that education is important since we're here today and we're in higher ed. That's an explicit bias. It's conscious, it's on our mind. The ones we want to be more thinking about are our unconscious or the implicit bias. And that is maybe operating outside of your awareness. It might be in direct contradiction to the values that you may be stating that you have. And it might be coming out into your affect or your behavior, and you may not even necessarily be completely aware of it. So for instance, as faculty, we value students. A concrete example that came out, one of the students came to me one time and said, I was in class, I had told this one professor what my name was, what my pronouns were, and the professor kept misgendering me. And it might have been one of those pieces up front that was in an unconscious or an implicit bias. So it might have been that person by their own, that faculty member by their own judgment saw that person as a certain gender and were just primed to use that person, that name and those pronouns. Yet when the student raised the awareness to the faculty member and said, this is what my name is, this is what the pronouns that I use, that faculty member refused to use that name and pronouns. And that was an example of moving from the unconscious and implicit bias into a conscious or explicit bias. Why does this become a problem? Well, it becomes a problem because then it impacts how we interact with our students, how we provide patient care, the decisions that we make, and then ultimately we're not getting into those spaces of provider and patient wellness because we have a disconnect there and where our biases are coming into play. And oftentimes we see this when it comes to sexual orientation. So we have to do what you're doing here today, is to stop and have intentional conversations, to take a step back and look at the content that we're teaching and say, is this inclusive across orientations, inclusive across identities and expressions? So we know that we can't 100% of the time cover every layer of human identity when we're teaching, but we can step back and say, are there ways that we can tweak this? Can we add in that will help be more reflective of our environment and our students and our faculty? So at this point, I am going to move out of the slides, and the question I'm going to give you as we watch this brief clinical vignette is, what biases do you see? And we will come back to that conversation here. And great pieces that came up in the chat about how to overcome bias, how not to say the wrong thing, how to include content. We're going to touch on that, and we're definitely going to touch on some resources. Okay. So the film we're going to watch here is about a 3-minute video vignette. The AAMC, the committee that I talked with you about during acknowledgements, I had the privilege of working with this group to not only create competencies, but then also to create a number of videos that you can use.
Tony, hi, I'm Dr. Henry. It's nice to see you.
Nice to see you.
I'm glad to meet you here in clinic, and I understand that you're here for a new patient visit.
I am.
Awesome. So what I'm going to do is ask you a series of questions that'll help me understand hopefully more information about you and also how I can best serve you to keep you healthy. Okay. Tell me a little bit about yourself in terms of any health issues or concerns that you've been told that you have.
No health issues or concerns. High blood pressure is a thing in my family, on the maternal side, but I haven't come across any issues.
Like mom has high blood pressure? Okay, gotcha. All right. Have you had any surgeries of any kind?
No.
Okay. And how about any allergies to any medicines?
No allergies.
Okay, great. And are you taking any medicines right now?
No, none at the moment.
All right. And tell me, let's see, are you single, married, do you have a boyfriend?
No, I'm single.
You're single.
Mm-hmm.
All right. All righty. And when's the last time that you had a menstrual period and pelvic exam, pap smear, that type of thing?
Haven't had that.
Really?
No,
Ever?
No, I don't have that equipment.
I'm not sure I understand. What do you mean you don't have that equipment?
I am a trans female.
Oh, I'm sorry, I didn't realize that.
So I just be careful. I was a little offended, not a little, very offended. So,
oh, I'm very sorry. That was not my intention to offend you or put you off in any way. I certainly want to be able to take care of all types of patients who come to see me, including trans patients, and this is certainly an area where I think I need to learn more. I apologize, though, for offending you, and I hope you accept my apology.
thank you.
Maybe we should back up and start over a little bit, and I can try to work with you to ask some more sensitive questions about who you are and what your health is like. Is that reasonable?
That would be great. Yes, please.
All right.
Thank you.
Thank you so much. Let's start over now.
So as I'm bringing the slides back up, if you want to jot in the chat, and I saw a couple of folks who were adding in what were some of those biases that you saw. And so we have a comment about a boyfriend assumes straight, that the grimace with, you know, what do you mean, don't have the equipment. Were there any other biases that you saw that came out during that interaction? And you can jot those in. So some of the other things I'll add on here: assumed menstruation, did not ask pronouns, so all good things. One other thing that might have helped the provider up front is if that chart or that medical record had expansive gender options, had maybe orientation or relationship options that expand outside of, say, a heterosexual focus or a procreative marriage focus. So yes, we have made progress in terms of marriage equality. However, we're still at a point in the healthcare system when folks hear the term married, they often are assuming that that means a male-female relationship and not a same-gender loving relationship or a trans relationship, pansexual relationship. So I'm gonna just quickly touch on this concept about cultural humility. And it is, you've maybe heard, there's a boom when diversity language came out around whether it was diversity, equity, inclusion, whether it was cultural competency, cultural sensitivity. We're really moving in the space of cultural humility. And so what that means is that you're able to take a stance that's other oriented, meaning that you're open to understanding different aspects of a cultural identity that are most important to the person. So it becomes less about you and more about understanding them. And if we stay in that humility space, it's less of a destination and more of a journey. So when we're using competence language, particularly cultural competency, it seemed to imply that you could get to a point where you sort of knew it all. And that is just never going to be the case. And sensitivity, it might say that you're aware of it, you might be sensitive to it, but you're not necessarily open. And so with humility, it means that you might get it wrong. So when we were watching that video, what you saw the provider say is, yes, the provider offended the patient up front, but then the provider had the humility to take a step back, apologize, and say, let's try this again. So you're doing a great job by being here to learn how you can work best with your students. Chances are at some point you're going to get it wrong, and that's okay. It's the taking that step back and that humility piece. To give this visual, that oftentimes when we come today and we're talking about LGBTQ health, and I had you, when you looked at that word cloud, say, what are my biases that come to mind? A lot of times when we put those letters up, immediately folks' heads go to what sex behaviors are they engaging in? Are they at high risk for HIV? They don't go to these other aspects of the human experience, be it their race or their age, their background, where they live, what their education. So I'm guessing social determinants of health is not a new concept for the folks here. But this visual tells you that we have so many layers to who people are as humans, that you may identify as a lesbian and a Black lesbian, and your job might be more important to you than your race or who you love, or your gender identity might be more important. And so we can't automatically assume that when somebody shares their sexual orientation with you, if they do that, that automatically means a nuclear family, or a wanting to have 2.1 kids. Some of these privilege, historical social norms, as the social norms have been shifting. Documents. So moving into this place about creating safe spaces for students and institutions. Part of that AAMC committee that I was talking with you about, when we were putting the competencies together, we did a good canvassing of what's out there. And the creation of a safe space is really about trust. It's where can I bring my authentic self? Can I come into being my whole me when I'm, say, here on our talk today? Or do I have to be a different person here than when I walk outside because of fear of my safety, or fear of something that's going to happen to me, or hold me back, barriers that are going to be put in place? And Shane Snowden did some great work with what was called the Gay and Lesbian Medical Association. They've since shifted to GLAMA, health for all health professionals. So it's not just for gay and lesbian folks, but for folks across identity spaces. In this paper, it's freely available online, and I can also get it to Christina after today's session to share with you. It's got a great number of recommendations for not only enhancing your students' environment, but also for your health professional schools. So for example, one of the things that I had to do here at Morehouse School of Medicine in Atlanta, we're a historically Black college and university school. I've been here 13 years, and when I was first here, I had gone to speak at a panel for medical students at another institution, and when I was there across town, they said, hey, we're getting folks from your school because they don't have a space. And I came back to my school and I said to our head of student activities, what's the process for going about having a student organization? And usually your students drive that, at least they do in my institution. But what I did, because there was a need, was I put together a paragraph, said, hey, is there an interest in having a group that focuses on sexual orientations and gender identities, and particularly the intersection with race? And all of a sudden I had people coming out of the woodwork, students who said, yes, we want to have these dialogues. Interestingly, when our student group started, we probably had more faculty and staff showing up because they needed and wanted to learn. In these recommendations, it's everything from what does your admissions process look like? Are there fields and checkboxes that are expansive, or are they just male, female, or are they just, an assumption of heterosexuality, kind of that, what's your relationship status, married, divorced? In your institutions, do you have equal opportunity employment statements that specifically articulate not only gender identity, but gender expression? So I can't be fired because maybe I present in a way to work that doesn't line up with, say, the institution's perception of what it means to be a certain type of person. For the students, are they seeing content in their curriculum? So props to all of you for taking a look at that content that you teach and saying, is this representative of the patients they're going to be caring for, as well as the identity spaces that they're bringing in? I know in my institution, I've had to raise awareness around language for more inclusivity in equal opportunity statements, as well as that bathroom sign that I gave. So we have had a number of trans folks who've come through who've said, hey, I'm not sure where I need to go to the restroom because all of these are binary spaces. Websites, they look for those. So on your website for students, are you showing, even if it's the visual of the rainbow flag or maybe an alliance type of group? Students, when they want to come to your institutions, will canvass your website to see, is this going to be a space that I can bring my authentic self, or am I going to have to be closeted and only show certain aspects of my identity? Med school, curricula and inclusion. So there are ways that you can infuse versus having to create more time. I don't know about you, but I know there aren't spare 8 hours anywhere for us to add new things. And as new technologies come about, we're in the pandemic. I know COVID has jumped in. COVID is now a part of a lot of different things in the medical school curriculum. It's been more infusion than it has been. We're now creating a whole separate class. So in cases, so when you're using cases in your any discussions, whether it's foundations courses, whether it's a certain clinical condition, maybe it's an anatomy, you know, that's a good space for you to be able to change up the identities of different patients. In some cases, it may not change much. In other cases, it might be a flag to raise issue or dialogue about disparity. So for instance, if you're going to talk about smoking, you might want to make sure that you're bringing in LGBT populations because there's a higher incidence of smoking rate. The same thing with drinking. Oftentimes those have been coping mechanisms for not being able to be valued in a visible space. The exams. So having those identities in there. I teach a lot of the sexual health content in our institution. When I'm teaching sexuality across the lifespan, you know, I'll throw a number of different identities in because, hey, guess what? It doesn't matter if you're 12 or 13. Puberty is something we got to talk about, whether you're identifying as gay, lesbian, pan, bi, fluid, it doesn't matter. But to see that visibility in there means that we're getting our students prepared to be able to care for patients across a number of identities. Same thing with our OSCEs. So, you know, I do say across these, make sure that you're including the health and wellness aspect and not just the disease, disaster, dysfunction. So it's easy for us to pull in the disparity space and say, hey, when we're talking about HIV, we need to talk about Black gay men or Black men who have sex with men because that's a population where we're seeing some pretty high rates around HIV. But are we talking about what do healthy relationships look like for Black gay men? Are we talking about maybe the work environment, other aspects of our human experience that are key that don't get as much playtime because we tend to stay in that more disease, disaster, dysfunction? Clinical exposure, I'm not sure, I did see from your website that you tend to be more community-based. We are as well. We have a number of rotating sites. And so if we can't take and get our students into exposure in a number of spaces, how are we intentionally creating that? We've had to move to Zoom OSCEs, and so being intentional to bring in identities that maybe we're bringing in racial differences or ability differences, maybe we're bringing in age differences. Who's in your backyard? What are those community partners? We rely a lot on our community partners, not only as clinical spaces, but also because they share those real life on the ground lived experiences in a way that might be allowing for some aha moments that might not feel quite as personal as if you're on your own community campus. And then I say infusion versus electives. So we can't just put sexual orientation work and gender identity work in electives in the clinical years. We really need our students to be, in order to be culturally humble and use that cultural humility in patient care, it can't just be here, you who care about it, you come and take that elective in 4th year or as you're headed into residency. We've got to find those ways. So whether it is when you're doing embryology or anatomy, physiology, when you might be talking about lab values, getting to a point where you're infusing different orientations and identities will help bring more visibility and more normalization. So I wanted to give you some lessons learned from work that I've been doing the last 20 plus years, is that you have to be open to listen and learn. I always say, you know, listen to hear, not to respond. So especially if I'm working with students or patients and they know their bodies, they know their labels far better than any of us do. And being open to not only learn, but then to take and hear and use. So if somebody tells you, I love this piece about intro of everyone asking pronouns. Absolutely. What I will tell you, and you will see some caveats, again, nothing is ever perfect, as folks, some will feel, particularly in the trans community, as if they're not out, and then you do a pronoun activity that may out them. So again, just being aware that when you introduce and use your pronouns and somebody says, you know, they're not open to using their pronouns, that's okay. There's always that opportunity to, you know, to talk with those folks at a later time. The open-ended questions, absolutely tell me a little bit about yourself. That works really well in sexual history taking. Please, 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 we have moved far past, are you having sex with men, women, or both? That is problematic language because it implies a binary. It may work for some, but a better way to shift and reframe that is tell me a little bit about your partners. You know, tell me about the genders of your partners. If you can do it in that way, it allows for more of that dialogue, that creation of space for dialogue. So I know we're in a crunch in the clinical arena for time, and it's much easier to go through that checklist of boxes. However, in the long run, it's going to help you more to build that trust, to build that the humility in the relationship, even in the ED. So I was an emergency department nurse, and I will tell you that if I could create that trust up front, it helped me when it came to providing a care plan that really worked for the patient. So infusion, a lot easier than finding more curriculum time. So that's where I would say take that step back and look at your content. Tap into your local organizations. And I'm going to show you an example in the next slide or two about how that works really well. They also become referral spaces if you're students. So I've had a lot of students who coming out in medical school, this was the first time that they were coming out and needing to transition. And if you can imagine, you're coming out for the first time, things that are pretty emotional in terms of, do I have support structures around me on top of my med school experience? The same thing for faculty and staff. So oftentimes what we've seen over the years is that folks who've identified in a sexual or gender minority space oftentimes have faced a more challenging road in terms of getting promoted, or their scholarship isn't valued as much. And so those are key areas for your institution to be looking at as well, and maybe connecting to some of those implicit biases that we were talking about. Intersections. So not every, you know, I know on your website you showed some racial diversity. I was going to say the intersections to identities. We're a historically Black college and university. We still get a range of identities who come through. So race, ethnicity, culture, these number of layers play into how one internalizes what their own sexual orientation or what their gender identity and culture means for them. None of this means anything if we don't have accountability. And so I don't know if in your institution, like in mine, when it's LCME reaccreditation time, or it's the end of the year and we're looking at the graduate questionnaire, and we're always looking to see what were students' experiences of it. If they say things on if they bring it up in clerkship, and I know sometimes we see this as, hey, I got treated like this by this nurse or this tech or this resident. Question is, did you do anything about it? If microaggressions are coming out, do your policies help you so that you can sit down and have that dialogue, so there can be some professional development goes on? Or is it really an egregious behavior so that you know, that student's not going to be successful, or that there's going to be a bad clinical encounter? Allies are more than straight people. And so this concept around what it means to be an ally is, we can't assume that because, say, maybe I identify as lesbian, that I'm automatically an ally for every other letter in the identity soup alphabet. We can't assume that just because someone identifies in, say, a sexual orientation space, that they're necessarily an advocate or an ally for the trans community. We've seen a lot of dissection, dissension, pulling apart within those communities. So we don't want to assume that just because someone says, hey, I'm an ally, that, you know, you're straight. So again, we want to be asking, we want to be having those dialogues and conversations. I wanted to show you this case example because this is a good example of a community organization. So a number of our partners here locally came together and they put together this Georgia Trans Resource Guide, another freely available resource, and I will get that to Christina to share with you. And the reason I bring it up is because this resource guide talks about these other aspects of life. It talks about legal. So if I need to navigate name changes, if I need to navigate employment, it talks about where are safe spaces for me to go and worship, or religious places. It talks about different healthcare specialists. So sometimes when you hear trans, you're immediately thinking hormones. Are we thinking about any sort of surgical modifications? We're not necessarily thinking about where do I get clothing, or how do I get social support, or how do I get housing support if I've now been kicked out of my house. Visibility, events. So as I mentioned, this week was National Coming Out Day. There's also National Trans Day of Remembrance, which honors all the lives of those who've been lost, because unfortunately, when we hear trans folks, we still have a very high murder rate that is associated with the community. We need to be moving out of that. We need to be moving into how to help folks be visible, live their authentic selves, get into care, and not experience violence and aggression. Okay, so we've got about 5 minutes or so left. I wanted to allow time for you to bring up what's going on in your institution in terms of what works and what needs improvement, things that you especially needed help with. Let me show you my last couple slides. I will come out of it, and then if you want to either use the chat function or turn mics on and we can have a dialogue. A couple of the main resources. It's good to know the GLAMA, WPATH, they're great for being able to send patients and students to. The video that I showed you today, there are 20 clinical vignettes, there are a bunch of faculty development videos. There's also the book that I showed you that has cases in it. So we've tried to do some of the legwork for you to make it easier, given we know that it's hard to have time to create new curricular materials. And then also I put up ASEC's link to certified professionals. So know who's in your backyard and in your community. You may need to refer to a certified sexuality educator, counselor, or therapist, whether that's for you, whether that's for your patients, your students, or other colleagues on campus. And then please ask the hard questions and keep asking yourself hard questions. This is an area that is constantly growing and changing. I will say that depending upon the political administration, rights are given, rights are taken away. Under the last administration, we saw more rights given. So we saw marriage equality came about. We saw more conversation about trans visibility. Under this current administration, we've seen many of those rights. Marriage is still up for discussion, but we saw some trans rights taken away in terms, particularly in the military. So if you have specific questions that you want to raise, feel free to either unmute or put those in the chat. Let's see. Thank you for this. The AMC is in 5 having a webinar creating, yes, it is having another webinar coming up here soon on creating safe spaces. So definitely more and more materials coming out.
Hi, this is Dr. Krell. I had a question about getting at biases that people can hide. So a lot of people who are biased are really good at faking that they're open, but then when they get inside a closed door with a patient, their biases come out. But yet when they're interacting with colleagues, they know what to say. So how can you identify and work with those individuals?
It's a great question. A lot of times when we see that come out, it's on whether patient surveys, satisfaction surveys. think when it comes to dollars and cents, that tends to speak. I think what we have seen that's been helpful is initially to call people aside, to share the findings, more visibility, more awareness. It's also, if it's done as an institutional culture climate, that in my institution, our vision is about leading in the creation of advancement of health equity. So everything we do is rooted around that. So I would say, if you look at your clinic practice, what are those values that you hold, and are you holding your practitioners accountable to those values? So call out, have conversation. You might be having some videos that you want them to watch. Maybe you want to do journal club that talks about and brings out some of these contentious areas for conversation. I will say that what we've seen has worked the most is when patients or students have complaints, the administration tends to listen and want to find a solution and a strategy. And so you can either do it as education for everybody, or you can do it on an individual basis. If it becomes really egregious, then you need to have a disciplinary action in place. But if you don't have those policies up front and say it's through your human resources, if the rates aren't protected, then it becomes more challenging to move up a disciplinary action plan if the person isn't going to kind of take a step back and do some of that unconscious bias work.
Thank you.
You're welcome. Well, thank you. I know we are right at time, and wanted to turn it back over to Dr. Vadaya and Christina for closing comments.
Okay, thank you so much for this enlightening presentation, Dr. Bayer, and we really, really appreciate it. And also, thanks to all the participants for attending it. And together, we definitely gonna make the university and medical school a better place for everybody. Thank you. We also have Dr. Chatterjee, our dean, and I would love if Dr. Chatterjee want to say a sentence or two.
Thank you very much, Dr. Vaidya. Dr. Bayer, that was a fantastic presentation. I really enjoyed listening to you and learning more. That's my provost calling because I have a meeting with her. But this was a wonderful opportunity for us, and we're very grateful for the education you've provided. I think you've given many of us things that we need to think about with regard to our curriculum and how we can do better in educating our students and residents as well as ourselves on this very important topic. So thank you very much.
Thank you for the opportunity. And I know there was a question that did come up about peer review research articles on healthcare inequities. The book on the AAMC side is a good place. Also, the National Institute or the Institute of Medicine did a whole rundown of where research was needed in these areas. Also, Healthy People 2030 has come out, and I'll point you to that website, which does a good job of outlining disparities in healthcare for LGBTQ populations. So those are great places to start. But we do still see, also SAMHSA has a number of great modules that break down not only the mental health, but some of the physical health as well. So you can see they're in pretty good sort of bite-sized fact sheet type pamphlets, some of the health disparities that currently exist. So that may be helpful for you to have on hand with your faculty and your patients. And Christina has my contact information. If you have further questions, please feel free to email me. I'm happy to connect.